Bangalore, India. It's nice to be on a forum like this because I grew up in Bangalore, left India when I was in 12th standard, did my undergraduate at Michigan, went to medical school at Mount Sinai, and then stayed on at faculty at Weill Cornell Medical College. And in 2015, decided that home is where I want to be, and I moved back, and I have no regrets since then. I now head the GI surgery program and the surgical program for Manipal hospitals in Bangalore. Sorry. So moving right along, we have an interesting topic today, which is the application of robotic surgery. And we have two fantastic speakers giving us their insights, and just chatting with Dr. Subhash Khanna briefly before signing in. He's done 8 robotic surgeries today, which is certainly a large number. So we would love to hear his perspective. Just to introduce him, Dr. Subhash Khanna is the chief of the Department of Minimal Access, GI and Robotic Surgery at Swagat Super Speciality Hospital Institute, Guwahati, an honorary visiting professor at GSL Medical College, Rajahmundry. Dr. Subhash is founder, president of the Association of Robotic and Innovative Surgeons, trustee and past president of Indian Association of Gastrointestinal Endosurgeons, international academic convener, IAGES, editor of JMAS Journal of Minimal Access Surgery, and chief editor of recent advances in minimal access surgery. Dr. Subhash is the recipient of many prestigious orations and awards, including Santokh Singh Anand Oration, G.P. Sharma Oration, R.H. Karmakar Oration, Professor Chandramohan Anderson Oration. I knew Dr. Chandramohan very well, and Professor U.C. Goswami Memorial Oration. Dr. Subhash has been selected for the BC Roy National Award in 2017, which is a very prestigious award in India, and received Lifetime Achievement Award from the Indian Association of Gastrointestinal Endosurgeons during the IAGS meeting. He has more than 160 publications, including chapters and various textbooks and journals. So I think, and I could say that in our brief introduction, he called himself a simple general surgeon. So clearly, humility is part of his personality too. So with that, I'll introduce him and allow him to speak to us. I'll let him take over from here.
Thank you, Dr. Govind Nandakumar, and thank you, Dr. Arun. Thank you, GAPIO, for inviting me to this program today. I am Professor Subhash Khanna. As Govind Nandakumar introduced me, I'm a plain and simple general surgeon. I also represent a society, the first robotic society of India, a global body born in India, that is the Association of Robotic and Innovative Surgeons. We are in robotics and also in newer innovations. When I was doing surgeries today, apart from robotics, I was also doing a single incision surgery. I was doing a spyglass cholangioscopy. We were doing some fascinating work, but which is a general surgeon's domain. And once again, thank you. I am supposed to be, can I share my screen, please? So thank you, Dr. Arun, who has asked me to speak on share.
While we're pulling that up, I'm just going to make a couple of comments. Please put your questions in the chat box. So if there are any, we can collate it and ask them in a coherent way. Please mute your mics. And
are we set to go?
Please go ahead.
All right. So what I will be doing in the session today, I will be giving a brief overview of a general surgeon's domain, and I'll be basically focusing on GI surgery and hernia surgery. And my agenda also would be what are the changes in the last 3 years, and where we were in the year 2018, 19, 20, and where we are today. So I bring greetings from the Northeast India. I'm one of the people representing the Northeast India, and this is a tree production state. We are the highest exporter of tree in the world. I also invite you to the World Congress of Endoscopic Surgery being held for the first time in India. And this is in Kolkata on 23rd, 24th, 25th, and 26th October. Please do not miss that. We go all across the world to attend world congresses. This is still happening in India. My short agenda today would be to give a glance of emerging and changing trends in robotic surgery, and how how the emergence of new systems have impacted us all, not only all the specialists. And I'll just share some videos of my library if time permits. When I have been talking on various subjects, and whenever we speak, we look at all this innovation. We call it tomorrow's world. This is a part of my presentation which was there 4 years back. But then today, I think almost all of this is today. It is not tomorrow. 3D printing, narrowband imaging is a routine in our center. Color-coded surgery is a routine everywhere. Bioprinting, without bioprinting, you cannot think of doing a jaw implant or a knee replacement or a hip replacement. But then out of all, the most fascinating thing has been the robotic surgery. And beyond that, probably we'll be doing very soon, we'll be doing robotic endoscopy and robotic nano surgery and telesurgery. This is a popular picture in one of the articles, and also available on LinkedIn, which tells us where we stand today so far the robotic is concerned. So more than 112, in fact, robotic companies are in the pipeline. Even yesterday, when I was taking an interview of startups, some startups are working on my principle of developing a tele-robotic ultrasound machine where the sonologist can do a ultrasound from home. So there are people working on robotic MRI inside the ICU. We don't have to take the patient to ICU. But look at this. Interesting fact is there are more than 20 robots which are working only on the abdomen. So this is a very, very interesting aspect. So not only the dental, the ophthalmology, the ENT, the lungs, and the spine, and the transanal robotics are there, but the main focus of attention today is abdomen, and abdomen belongs to most of the general surgeon. When we look at autonomy, we are at the level of LOA1, where human surgeon directly and continuously controls the robotic system. And we are not given more than this autonomy, but the fact remains LOA4 and LOA5 are going to be there. We all know that whatever we have read in history of whether it is in Gita or Ramayana, whatever you have read, these all things are happening. So whatever is today, you can imagine it just happened. So LOA, when a complete robotic treatment planning would be done by robo, is also probably will be there in future. The utilization of robot is this, but this is going to change since the robo has come to the hands of GI and general surgeons. And today, 19% of the population of US has a access to robotic system, whereas only less than 1% in India, which has a huge population of 140 million people. Similarly, less than 1% in Asia Pacific, China 1%, and Japan 5%. So this scenario is changing, and the why that is changing, because the revolution of minimal access surgery was there. We all know it. This is one of the revolutions of this century. And the next revolution probably is now robotic surgery, because robotic surgery has taken up all the disadvantages of the laparoscopic surgery, where we used to have a straight stick effect, something like a hockey stick. You have a straight instrument. If you are doing a surgery on the left, your hand would be on the right. So the Da Vinci used to be the first. I think I have missed the image of the Da Vinci robo, but then it remains the leader, and it enjoyed all the benefits of having all the patents till 2019. It also have an advanced iris technology, Firefly technology. I think I won't be speaking on all this today. It also have advantage of dual console and choice of staplers. But then let's look why such a demand. And this is also related to a general surgeon and GI surgeon. The demand increased When we started the association in 2020, there were only 96 robots in the country. In 2020 to 2024, 3 batches of surgeons that include oncosurgeons, ENT surgeons, urologists, gynecologists, and oral surgeons, and endocrine surgeons and pediatric surgeons who are undergone training. Suddenly there was a huge demand. In 2020, in March, when we started an association of robotic innovative surgeon, and when the patent of Intuitive, most of the patents were gone, and new open systems started coming, new system providers started coming. And then from 2020, when there was only Da Vinci was available, then suddenly the Mantra came, the Vercius came. The first to come was Vercius, then came the Hugo-ARIS, and then SSI Mantra. And today you see SSI Mantra had only 2 or 3 installation when I started. I was presenting last year, and today they have about 40 installation in the country. Vercius has 40. Da Vinci has 170. Hugo-ARIS has been a bit on the slower mode, and they have only 6 so far, but I think they will soon catch up. And this only occurred because not only for the association, because there was a demand by the surgeon. So the demand was from 191 in 2020 to 148 in 2022, and today we have 170 plus 40 plus 40 plus 6 are altogether 256, almost 2.5 times than what it was about 4 years back. And this was the changing times. The thoracic and colorectal surgeons were doing the maximum and then suddenly the demand rose, and the general surgeons came here. The general surgeon, the blue is showing the urologist also increased, and then the gynecologist. So this demand started increasing, and suddenly from 50K to 600,000 robotic surgeries per year were happening by the general surgeons. So I won't go into the details of what are the negative limitations and negative aspect of laparoscopic surgery. We are always there to develop something which will be for the benefit of the surgeons and the society. So what we are today is you are sitting on the console, and you are ergonomically superior. You have an image which in front of your eyes. You have a telescope control, complete vision control in your hand. In energy devices are either in your hand or in your foot. You have a beautiful dexterity. We call it 6 degrees of movement, 7 degrees of movement, and probably it gives you huge comfort and precision, superiority, and proper ease of dissection. Thus, what I want to say is, whereas even today, Da Vinci is the leader in robotics, with having the latest from 1 to 5 version, 5th version has come now. The open system came. So Da Vinci, we used to have the stereoscopic view. In open system, the surgeon could look at the console and talk to the team, communicate with the team properly, and could operate in sitting and standing position. This is not only for CMR, it is also for Hugo-ARIS and also for SSI Mantra. The next system is Hugo-ARIS, which is slightly bulkier. Oh. But then it is equally effective. I won't compare which one is good or which one is bad, but then it is also there for a user. And then came the SSI Mantra. So these were the 3 factors which there were 3 systems which caused the changes in the installations in the world. And then and so here there was a surgeon console. The bedside units were separate, unlike in Intuitive, and then the endovision system. Now I will not go into the different parts of it. I'll just share what exactly is the domain of a general surgeon today or GI surgeon today. These are the cases done by us from 2020 February to 2023 September, June. So this is the domain. So a surgeon started doing cholecystectomy. I have done about 283 so far. We have published 110 data. Hernia, we have just done 80. In the last 2 days, we have done about 6. Then anti-reflux operation consecutively without doing any single laparoscopic this thing. We did about 40 ventral hernias and then other unnamed operation which I mentioned here as other operations. So this is the domain of a general surgeon. A general surgeon can always, a GI surgeon can always do. So let's have a look at the Kusum score or the duration panel. Whereas the duration panel is showing here 360, 300 minutes. This is this is from the database of the worst years. Our duration panel has come down to about 60 minutes for cholecystectomy. This is because we are routinely practicing. Over 10 to 50% of our cases are being done robotically. We also have brought down our inguinal hernia repair purpose. This is one of the best time. The negative means the best time we are doing in the globe. So ours is less than 100 minutes. So we are here, whereas the others are almost here. So and then we have the maximum number of cases. You can see are touching 80 today. Consecutively 80 TAPP robotic repairs. Anti-reflux operation also, I think we are scoring the best time. The lowest is the best, please remember, 100 less than 800 minutes we are able to do. Whereas I needed to do in 1.5 to 2 hours a robotic, a laparoscopic anti-reflux surgery. We have started doing this. And this is the very interesting score where it shows that our timing for cholecystectomy has come down drastically. And also the lower chart you must see, very interesting. So whereas we were erratic when the beginning of our 3 to 354 cases, now we are not much erratic. We are almost stabilized, and we have a upper and lower limit of the timings. Let me see where we are. Sorry, what we are able to achieve. I don't think I will show all these charts now, but only thing is anti-reflux operation to start with, it was here, and this is the standard baseline across the globe, and we have come down to negative, and we are doing it in less than 60 to 70 minutes today. Similarly, with experience of cases, we have brought down all our time, consult time in almost all the surgeries. So with this is the domain of a general surgeon and a GI surgeon. You can do fundoplications, you can do achalasia, adrenal, spleen, hepatopancreas surgery. Almost all have become much more easier, much more doable. Apart from this, the bariatric surgery, hernia and abdominal wall reconstruction, thoracic surgery, urology, gynae, head and neck surgery, cardiovascular, and robotic pediatric surgery. I am totally excluding here from an oncosurgery. So this is the domain to which you can go on adding pancreatic surgery. What you can do LPJ, you can do a head coring, you can do a Whipples. So you can go adding almost all the procedure become possible. In HPB surgery, normal cholecystectomy, although we are amenable to laparoscopy, a complex cholecystectomy becomes much easier for when done robotically. CBD exploration, I do routinely. ERCP for a surgeon, if a robo is there, I would prefer doing it with the help of a robo. So exploration of coronary drug became a routine with us when we started doing robotically. So HJA, choledochosis, partial hepatotomy, total hepatotomy, donor hepatectomy, robotic liver transplants, and robotic Whipples all become easy. So have a look at some of the procedures done by us. These are slightly older videos. I didn't get time much to edit so many, but we have enough. Every month we do about 15 to 20 minimum cases. And as Dr. Govind just now said, at times we do 8 to 10 cases in a day also. Gangrenous gallbladder, we could not think of doing robotically a couple of days back or couple of months back, and now we can see how easily this is feasible. So what I'm showing you is a feasibility and the horizons of doing the procedure by a general surgeon. Even if the half of the GB here is black and greenness perforated, the cystic duct and the cystic artery is intact and it is very friable. You can always go and suture it there, because the as we all know, the ergonomically and plus the precision of dissection and plus the superior of dissection and superiority of suturing is always there. These are cases in yesterday and today we have done one completion cholecystectomy. I wish I could show you how the GB is left out by the surgeons, which needs a very proper dissection, and for that you need to have a robotic dissection. This is one patient, because here the GB is only half or less than half is a remnant. I call it a completion cholecystectomy because these patients do have more than a remnant. A remnant is 1 centimeter or 1 centimeter. We sometimes get a whole gallbladder. This morning I was doing a remnant GB. The whole GB was there, and the surgeon I should not say foolishly, had a bleeding here in the fundus, and he had put two. We got two hemoclips inside the fundus of the GB. So that was very, very interesting finding. Maybe in the next presentation, we'll try to show you that. So this is an empyema in a remnant GB with a calculus, where you can suture the cystic duct and open up the GB, take out the stone, and do a cauterization if it is very small, not possible to remove. So we to remove a complete cholecystectomy, you can always do a partial and come out and giving still benefit to the patient. CBD explorations. This is one which was not my domain, but with the help of Robo now, you can see a large CBD, even a small CBD can be done nicely. You can see the precision of the incision, the stone being taken out. You will see the stand being put, a DJ stand, and you see fine suturing. So all this become very, very amenable, and it is amenable to any general surgeon. This is a forgotten stand where I had attempted ERCP 3 times. As I'm a flexible endoscopist, we tried, but we failed. We kept on trying, but the patient won't go anywhere. He has forgotten the stent which we had put about 2 years back, and now he came back, and this was the stent which was taken out and robotically, and we did a removal of all the fragments. CLD became a routine for us. So because the liver is hard, fibrous in child B disease, you don't want to retract with a strong retractors in laparoscopic surgery. So you just want to do a gentle surgery as much as possible. So they do fairly well after the surgery. This was yet another patient. So I'm just sharing with you some of the videos to make general surgeon understand that this is the domain of a general surgeon. He can do wonderful work with this. So this was a perfected GB where we had done a transcutaneous cystostomy, was done in my absence by one of my colleagues, Dr. Barua. And then we went inside now, separated the GB from the anteabdominal wall, and dissected as a duct and the artery. And now it has become very easy. Of course, an experienced surgeon can also do laparoscopically, but then this is far better if it is a prolonged surgery to do robotically, we can do with more precision. These are smaller, simpler operations, both laparoscopically and also robotically. But the biggest advantage in robotic surgery is an early recovery, what we have observed, and also much less pain. So this is a retroperitoneal cyst, a huge one, where the party insist wanted a robotic surgery. So I think time won't permit, so I'll just make it fast and show you. So these have become these are all routine. This was the publication of first 106 cases where we found the pain score to the range of 0 to 4 in first 6 hours, and almost 0 to 1 in the next 24 hours. Hernias is almost a routine for us robotically. These are the ports for a groin hernia, 2 midclavicular, 1 supraumbilical, because we don't want to be very close to the to the incision where we need to suture. And then we usually use a textile mesh. You can see the peritoneum being dissected from the fascia transversely. We are putting a mesh. I'm sorry, it is almost 3x, 4x, but to save time. And then you can avoid tackers. We sometimes put a glue, but no tackers in any of our cases. Bilateral groin hernia, we can do one side dissection. We can also cross the midline if there is no doubt of a patent uricus and go to the other side, and can have an overlap in the midline and can have a very beautiful dissection. The ease of dissection in robotic is just unbelievable. So in the midline, if you have here, it looked like a thicker tissue. That's why we avoid it. But in the midline, if you can go, you can always overlap the mesh because you want at least 2 centimeter overlap in the midline. We also try to put pro grip mesh. It's slightly difficult to put, but you can avoid tackers. You can even avoid glue. We routinely put glue in almost all our cases where there is a doubt or the sac is large, but I won't say routinely, we sometimes put this. So this is again a 3D anatomical mesh, textile mesh we are putting, but you can put any 3-dimensional mesh. It sticks very snugly, but you need a proper dissection, and that is only possible with robot. Of course, laparoscopy dissection is possible, but robotic dissection is much superior. You can have very precise. You don't want to dissect for more or less because you don't want the mesh to migrate. So at present, I won't say the superiority of the robotic hernia over laparoscopy hernia has been proven. But then once we come with our publications, we will be publishing our first 100 hernia data very soon. And similarly, we are expecting many other will publish their data. And so TAP is feasible and safe. It has all the advantages of robotic surgery, whatever advantages we know of. Cost and docking time is a concern. Normally, we need about 5 to 50 minutes for docking. Overall PAIL score, as I said, is much less compared to laparoscopic surgery also. Currently, my comment here for hernia is currently robot-assisted surgery is facing the same question that MIS had faced in the beginning. Acute abdominal emergency, have a look at this. Some of these. These were all accidental encounters. Patient had pain abdomen. We wanted to go in. We found an omental, torched omentum, and we went and did it robotically because we wanted a precise dissection. And these are more of demands than this. Anyway, the patient was diagnosed with appendicitis. We thus thought of removing the appendix also. Gynecological encounter, there are many because only 2 or 3 videos are there. If you wish, we can have a look at this. I think I have another about 7 minutes. So here you can see how precisely a twisted ovarian cyst can be removed by saving the ovary. You can see the ovary is saved. And pregnancy, the patient is in shock. If there's no contraindication, then you can always go in. You can do a precise dissection. You can do a septectomy. You can also do a salpingostomy if the patient wants to have a future pregnancy. So these are all doable. Dermoid cyst, young girl, she wants this ovary here in the thigh. She wants the ovary to be saved. You can do a very precise dissection, save the ovary and take out the dermoid cyst without puncturing, because no gynecologist will allow you, and no one surgeon wants it. So I would think I'm coming to the last part of my presentation, the fundoplication, where do we stand, what is the technique, and are the results comparable? There is no doubt about it. All those things we did, the first robotic fundoplication was done in 2001. This is the first case report in the world literature. There were many meta-analyses, but they were all smaller cases. We in a small center have done 40 cases in the last 3 years. So 226 cases in 6 randomized trials, probably still less to go interpret. But then this was always associated with increased operative time and procedure cost. So it was only kept for redo fundoplication and redo hiatal hernia surgery, not for us. So for us, it is almost unthinkable that having a robo here if the patient is affordable, what to go for laparoscopic surgery. So this is one trial which is very one analysis 2004 5 total patient 40 and 20 in each group. So this for us, these are very small. For Indian population, these are very small number. You cannot have 20 and 40 and give your data. So I'll just these are the ports of us for robotic fundoplication, one epigastric port for liver retraction, a camera port, 4 finger above the umbilicus. R1 and R2 are 2 ports made for dissection, and A2 is an accessory port. And let's have a quick look at, so almost all the steps of fundoplication done laparoscopically can also be mimicked and can done in a better way with a robo. So I've shown the port positioning, the equipment we have seen. So what we do is we go in, mobilize the gastrohepatic momentum here, taking care to avoid injury to the accessory left gastric artery, separate the esophagus from the right crus of the diaphragm, then go to the left esophageal ligament, separate it, and we can do dissection both from the right and left. So now I am right side dissection. I could not show you properly. I think let's try to see the vagus nerve there. So here you take care of the vagus nerve here, lift it up with a umbilical tape. There's the vagus nerve on the here, somewhere here. If you zoom in, I think you should be able to see. Close the crura with Ethibond. Depending on how much is the fact, you will take a call whether I need to put 1 suture, 2 suture, I need to put a mesh, and then and do a wrap. In population here, we hardly have needed any short gastric vessel dissection, and we follow that Scandinavian technique. We don't do that, and we simply go for fundoplication because the fundus, we go for a wrap because the fundus in our population is quite large and capacious, and very comfortably a wrap can be done without any problem, without cutting the short gastric vessel and without causing any atony to the fundus of the stomach. So we can have a beautiful mobilization, wide window, wrap around this OE junction, short loose wrap, and we anchor to the esophagus. Spanic cyst, this is one. These are all simpler operations laparoscopically, simpler operation robotically. This is one. We also did one hernia with an undescended testis yesterday, very nice. But you can see the beauty. You finish the hernia and then you can lengthen the vas and the artery very nicely. Here I'm incising because we need to incise and separate the vas structures from the peritoneum, and I wish I could show you the convolutions and the lengthening of the vas here. You can see there the vas is there, now it is being lengthened. Now you see the convolution, so it becomes very lax and very easy. So you can go up to almost the origin of the gonadal vessels or the testicular artery. I think I'll finish with this. ERCP tried, I failed. There was a stone in the hepatic duct, went again with the robo and opened up the common bile duct, took my spy scope inside into the hepatic ducts, into the lower part. This is lower CVD, and then into the hepatic ducts. And here you can see the tiny hepatic radicles and this. So many innovations. So what happens here? Robotic is a platform which will open many doors for you. Ladies and gentlemen, I think I'll stop here. We'll not look into what are the new system going to come and how the hysterectomy is going to come, how the transanal and transoral surgeries are going to be done, how the miniature robots are going to come, how the future nano robots are going to come. These are all different big subjects. But one thing which I will say is take help of your company to have a complete database with you in your hand, which I have in my hand. Anytime I can watch my video, and probably next time when I'm coming to talk to you, I'll be from my mobile app of Versius, I should be able to give a live telecast to all of you of a procedure being done. And that includes my port positioning, everything in 100 cases, what by deviation in a port position, everything should be in the control of your hand. Today is a world of artificial intelligence innovation. So all these data is right now in the grip of my hand. Thank you very much, ladies and gentlemen. Probably time would permit me to proceed further. I would like to conclude with a single statement. Robotic assisted general surgery is the new future of surgery. We need to maintain robotic proficiency and need to have various procedures in our armamentarium. New platforms are there to explore, and the future is not promised to anyone. Let's make the future of everyone today of ours. Thank you very much. Thank you, GAPIO, for this invitation.
Thank you very much. That was a fantastic talk. I think it's commendable, to say the least, on how you have applied robotic surgery to various aspects of general surgery, from emergency surgery to others. Any questions on the floor? We're running a little bit late, so if there are any questions on the floor, we can take it. Else, I'll just ask one quick question and we can move on to the next speaker. Sir, how did you move? Did you move from an open surgeon to a lap surgeon and then a robotic surgeon, or did you move directly from open to the robotic platform, or what was that experience like? Maybe in brief, you can tell us.
Thank you very much. I'm doing lap surgery from 1992.
Okay.
Several thousands, probably 20, 25, 30,000 laparoscopic surgery I must have done. So it was very easy transformation from me. In about 20 cases, I was confident. And as per my Kusum chart, I can make out about in about 20 to 22 cases by time became steady, whatever time I was taking. Now I know how much time I need for fundoplication and how much time I need for hernias. There are aberrations and exceptions when it's a very difficult case. So for me, it was easy from laparoscopic to robotic. But today, most of the data says even an open surgeon, an open oncosurgeon who is never trained in robotics, laparoscopic surgery, can also transform into a robotic surgeon very comfortably, like a children playing or a joystick, say a game. So he can also transform. Only thing is basic knowledge of laparoscopic surgery is required. Otherwise, when you will stuck at robotic surgery, you will directly convert to open surgery rather than going into laparoscopic surgery.
Okay. Thank you very much. And in the interest of time, we'll move on to the next topic, which is an interesting follow-up to this talk. It's about how to keep our costs minimal and in robotic surgery, and how that may help us adapt and imbibe robotics in a cost-effective manner. To hear about that, let me introduce Dr. Arun Prasad, who is the clinical lead and senior consultant in GI, bariatric, and robotic surgery at Apollo Hospitals, New Delhi. 36 years of experience doing this. Dr. Arun has an experience of performing over 10,000 laparoscopic surgeries that include over 6,000 laparoscopic cholecystectomies, 2,000 lap hernia surgery, 2,000 thoracoscopies, 1,500 bariatric surgeries, and 500 robotic surgeries. Dr. Arun has the privilege of doing numerous world's first procedures: robotic, laparoscopic, thoracoscopic. Dr. Arun Prasad is former president of the Obesity Society of India and president of the International MGB-OAGB Club for Bariatric Surgery. Dr. Arun is an editor of the Journal of Minimal Access Surgery, World Journal of Gastroenterology, as well as reviewer of cervical endoscopy and obesity surgery, board member of EC Journal of Gastroenterology. Dr. Arun Prasad is currently the vice president of ARIS. Dr. Arun has published more than 55 papers in various journals. Dr. Arun Prasad was president of Obesity Surgery Society of India between 2018 and 2020. Dr. Arun Prasad is president of International MGB-OAGB Bariatric Club. Certainly a remarkable resume, and we will hear from him on the next topic. Thank you. Over to you, sir.
My loss, and I'm grateful to the organizers for allowing me to make this presentation online. So my topic is on robotics in bypass surgery. Is it worth the cost and time? Mankind has always been unkind to new technology, whether it is laparoscopic surgery or robotics or even the wheel. So let me share my experience and some comments from literature. To start with, I would like to say that I started doing robotic one anastomosis gastric bypass about 11 years ago, and the first one in the world was done by me in July 2013. What are the benefits? How do we justify the cost? The enhanced precision and dexterity. So robotic systems provide superior dexterity and precision through articulated instruments with greater accuracy. This is particularly advantageous in gastric bypass surgery, which involves complex maneuvers such as creating small anastomosis and suturing deep within the abdomen. Reduced risk of technical errors, improved anastomotic integrity, and lower complication rates such as leaks or strictures are the outcome of this. I am giving references from literature in each of my slides. Then when we talk about improved visualization, robotic surgery offers a three-dimensional high-definition view of the operative field, enhancing the surgeon's ability to visualize critical structures. Better visualization can lead to fewer injuries to surrounding tissues, reduced blood loss, and shorter operative times, which contribute to overall patient safety and outcomes. Then we have reduced surgeon fatigue and improved ergonomics. The robotic consoles allows surgeons to operate in a seated, ergonomically favorable position, reducing physical strain and fatigue. This is particularly beneficial for lengthy procedures like gastric bypass surgery. Increased surgeon focus and precision over extended periods, potentially leading to better surgical outcomes and lower complication rates. Shorter learning curve for complex procedures. For surgeons, the robotic platform offers a more intuitive learning curve for complex suturing and dissection tasks required in gastric bypass surgery. New surgeons may achieve proficiency more quickly, which can enhance the overall safety and efficacy of the procedure and reduce long-term training costs. Now, this is something that has been noticed across specialties, not just bariatric surgery, that newer surgeons find it easier to learn on the robotic platform to do complex surgeries. Reduced post-operative pain and faster recovery. Now, this is because of the precision and the fulcrum ergonomics. I'll talk about the fulcrum ergonomics in the next slide, which leads to less trauma to surrounding tissue, resulting in less post-operative pain and faster recovery. The quicker recovery times can reduce the hospital stays and allow patients to return to normal activities sooner, potentially decreasing overall healthcare costs, including readmissions and complications. So when we have the robotic cannula, it actually moves around a fulcrum and there is an end effector on the other side. So if you can see the slide, the movement always happens at the fulcrum. There is no side to side or up and down trauma to the abdominal wall muscles, which would normally take place when we are doing manipulation using our laparoscopic instruments through the laparoscopic cannulas. And this is the reason why a robotic surgery pain score is less than laparoscopic surgery pain score. And this continuum concept, what you see in the picture below, is how the robotic instruments work inside the abdomen without causing any tissue trauma. There is broader patient eligibility. increased precision and control of robotic systems can make minimally invasive surgery an option for patients who might not be candidates for traditional laparoscopic surgery like revision and high BMI super obese. So when we are talking about super obese undergoing two-stage procedure of a sleeve gastrectomy and a bypass at a later date, actually by doing a single stage robotic gastric bypass, I'm able to reduce the cost of treatment because we can do the surgery in a single stage. The enhanced precision and control of the robotic platform can reduce the incidence of complications that require reoperation, such as anastomotic leaks or bowel obstructions. Fewer reoperations decrease the overall cost burden on both patients and healthcare system, leading to cost savings that can help offset the initial expense of robotic surgery. Now, this is something that has been shown in many meta-analysis and multicentric studies as to how the incidence of leakage and bleeding is less with robotic bypass compared to laparoscopic surgery. As mentioned earlier, robotic systems offer advanced training tools such as simulation, telementoring, and provide opportunity for remote collaboration and guidance by experienced surgeons. The robotic platforms often have dual console where, just like the airline teaching, the surgeon can be sitting in one console with the trainee on the other. So better trained surgeons may perform procedures more effectively, reducing complications and enhancing patient safety, which can justify the investment in robotic platforms. Finally, robotic surgery can lead to better long-term outcomes due to fewer complications, reduced tissue trauma, and more precise anastomosis. This can translate to less weight regain, lower rates of post-operative complications. So it has been shown that over time, improved outcomes can lead to reduced healthcare utilization and costs associated with managing complications or comorbidities. So I'll give an example of a gastric bypass at a corporate hospital in India, in my hospital at Apollo in New Delhi, India. A laparoscopic gastric bypass costs about $6,000 while a robotic bypass would be $7,300. To take a split up, the stapler actually reduces the cost by $500 as the robotic shear form staplers in Intuitive Da Vinci is cheaper than the traditional laparoscopic staplers. Instrument costs get added around $1,500 and the drapes and miscellaneous costs another $300. So this is how we end up with a total extra of $1,300 in our patients in my center. There are a lot of questions, and the second part of my presentation is that about the time taken. Now, this is a video of 2013, 11 years ago, and what you see here is a clock at the bottom, and that is an SI Da Vinci robot being wheeled into the head end of the patient. And when we start our procedure, we are now doing the docking. That's the camera port. This is what we call as the arm 1. That's being docked. Now, the docking has become much quicker in the X and XI model. So actually, I'm showing an old video of how we were able to save time with good coordination in the theater. So you can see that the entire docking has taken about 45 seconds. And this is because the robot is ready well before we start the procedure, and everything happens simultaneously, and with coordination of the theater staff, one can do the docking in 45 seconds, which is less than the time taken often for the nurse in my theater to find the appropriate suture which I'm asking for. This is the My Intuitive app which has been developed, and this has got recordings globally of all the surgeons. I have been doing the surgery since 2012, and what you see in the center, this is a picture of 29th August, that is last week, when I did a sleeve plus procedure where it was a sleeve with bipartition. And you can say that it has taken about 42 minutes, of which total active time was 34 minutes. The graph here shows your last case. The chart here on the right again gives you further details. That's the console time, 42 minutes, instrument active time, 34. 4 instruments were used. And at the bottom, you can see the cartridges, the green and the blue cartridges, which were used. Firefly, which is the ICG, was used for 40 seconds. Now, this is another picture. Now, this was in June 2022. And you can see this graph, how it tells us about the time taken. And 33 minutes was the console time. I would like to confess here that if asked to do a laparoscopic gastric bypass, I will not be able to do it in this much time. I probably would take double the time of what I do with robotic surgery. So we did this small study where 30 cases each of laparoscopic and robotic bypass were taken. Step 1, induction to start of dissection. Step 2, time to take to pouch formation. Step 3, time taken to form the gastrojejnostomy. And step 4, time taken till extubation. Now, all 30 cases were done by me. And here we removed the bias because we are not comparing a beginner in robotic surgery to an experienced laparoscopic surgeon. It is the same surgeon who's doing the surgery. And you can see in this chart here, the yellow being robotic. The step 1, it took longer, while step 2 and step 3, robotic took less time. So effectively, if you see on the right, the skin to skin time with robotic surgery was less than the laparoscopic bypass surgery. Now, when we talk about robotic anastomosis, here you can see in this video, I'm making an inferior pouchotomy in an OAGB, MGB surgery. And what you see, an enterotomy being made in the jejunum. We are doing an end to side anastomosis, which means the pouch is at its longest. So it's not a side to side, it's an end to side. The ICG test being done. The anastomosis is being done in any GI fashion that I've been doing over the years, which is using a Cornell corner suture. So it's a 2-layered anastomosis after passing the bougie across. On the left, you can see how the robotic cannulas move around the fulcrum, and there is no tissue trauma, which we were talking about earlier. That less bruising is what causes less pain. This, we are reaching the end of the anastomosis. Again, an indocyanine green test. And after completing, we always do a leak test with methylene blue. Methylene blue is being filled in through the bougie, and the leak test has been completed. Always check the back when we do the leak test. Sure form stapler is what I was talking about. Not only is it cheaper, but you can also see it can be rotated and articulated in multiple directions at the same time. So it's like my palm inside. It's being used also to grasp the tissue. You can see how it's being not only used as a stapler, but also to grasp the tissue so that we can make the pouch in the desired manner. It has an element of AI. If you see the bottom left, the blue line, which is showing that the stapler has been clamped. And when it fires, it shows a yellow line. And this is the feedback which one gets. So it can compress, it tells us about the kind of cartridge which should be used. It's an excellent tool. So to conclude, while robotic surgery for gastric bypass incurs additional costs upfront due to equipment maintenance and training, these are offset by the clinical benefits and potential cost saving over time. The precision, enhanced visualization, reduced complication rates, and faster recovery associated with robotic surgery can lead to improved patient outcomes and lower overall healthcare costs, making it a valuable investment in bariatric care. While robotic gastric bypass surgery may have a longer setup time initially, the overall efficiency, precision, and enhanced capabilities of the robotic system can make the actual surgical procedure faster than traditional laparoscopic methods. These factors contribute to a more streamlined operation with less time spent on complex maneuvers, reducing the total operative time. So greetings from my team in New Delhi. I would like to end by saying change is inevitable, growth is optional. Thank you very much for listening to me. I hope I have finished on time. Yeah, it is 19 minutes, 13 seconds. Good luck and wishing you all a great conference.
Thank you. That's excellent and very succinct, to the point. Thanks for sticking to time. I think this is probably one of the most relevant aspects of robotic surgery, at least to increase adaptability and in our part of the world. Any questions from the floor? I mean, I think we're a small audience, so feel free to just turn on your mic and speak if you have a question or a comment. Dr. Arun, do you have I'll just make one quick question and then we can wrap up. For a budding center that's looking at, developing a program like you have, do you have any, practical tips for them to, should they visit a center like yours that's figured out the fixed costs and the procedure costs and done it in a way that is feasible? What should they spend some time in your unit? Should they? Is it part of the training program to figure out the business aspect of having a robo, especially if they have their own hospital, etc.? Could you comment on that, please?
Sure. So I think this robotic surgery is a complete teamwork, starting where everybody has to understand, starting from the owner of the hospital, the promoters of the hospital, the shareholders, the marketing department, the surgeon, anesthetist, the OR staff, and everyone. So I would say that when this technology is there, everyone needs to understand what it is all about and just not see it as a tool, because only when there is a comprehensive team approach that the program will succeed. Just one person running the program, it will not succeed. For the surgeon, yes, the surgeon should first visit certain centers where the program is already running, and they should visit the center along with their OR technician, the nurse, their first assistant, and even sometimes an interaction between the marketing departments would help. Then second stage would also involve where a mentorship is done, where an experienced surgeon is invited when you do your first couple of cases. So yeah, it would involve a bit of hand-holding and as well as learning from others' experience so that you don't have to reinvent the wheel.
Thank you. I'm sure you know him, but Dr. Venki is a good friend of mine. So I know that your institution has a vision to develop robotic surgery across the country, and that certainly helps in driving the program. Anyway, I think we'll end on time if there are no further questions. I think they were both fantastic talks. Thank you very much for asking me to moderate the session. Thank you to the two lovely speakers for sharing their experience and knowledge. Thanks to GAPIO for hosting the event. And also thank you very much for the technical team and for their coordination and getting the event together. Thank you very much. Enjoy your Saturday night if you're in India. Enjoy your Saturday morning if you're outside India, or Sunday morning if you're in Australia, New Zealand. Thank you and have a great weekend.
Thank you.
Okay.
Thank you very much.
Thank you.
Bye bye.
Good night.
Thank you.
Bye.
Bye.